All right, please join me in welcoming Dr. Kathleen Haycraft back to the stage.
So when I was a kid, if I ever got called Kathleen, I knew I was in trouble. And whenever I got Kathleen Elaine, then I knew I was really, really in trouble, right? Most people call me Kathy, but just good trouble. So I'm impressed with you souls who came back. There's fun things to do in Denver. I'm glad you're in the room. You know, I was in charge of the track for the specialty conference in Anaheim. And I brought the best of the best. They normally make $5,000 to speak. And I brought them in here for a very small sum of money. And they put the conference right next to Disney World in Anaheim. So in the afternoon with these great speakers, we had like 4 people. It was awful, but I warned them. I said, I don't think that's going to work. Just a question someone brought up, and it was good. Her daughter had suicidal thoughts after being placed on isotretinoin, and realized that any drug can do anything. And an N of 1 is 100 when it happens, okay? And she had some good points. And she was happy she put her on it, and she got better. She had to go off. Realize that will occur with many drugs. In the iPledge program, you do have to go through suicidal risk, okay? And it states if you have any suicidal ideation. So I'm not totally poo-pooing that, but just know the studies don't show it. And actually, the individuals that have the higher suicidal ideation are the ones who are not treated. So now we're going to big people. Who likes big people in the room? Yeah. Yeah, I like big people too. I like kids too, though. I like everything. That's why I have too many initials after my name. I know you can read, as stated before. You can read that. And the first thing I'm going to talk about, you know, a lot of people call this adult what? Acne, right? So this is rosacea. And if you take a look at this person, who's one of my patients, what kind of rosacea? Does she have just red skin, or does she have something else going on? Yeah, she's got pustular rosacea, so there's papules. And it's actually, in the picture here, you certainly see a perioral distribution. Be aware there are variants of acne that are perioral only. And this woman I treated only as perioral rosacea. That means around the mouth. You can also, the same person can have it just around the eyes. And that's the one type of rosacea that is not chronic. So you treat them with like 100 milligrams of doxycycline twice a day for a month or 2, and they're clear and gone. Having said that, it's a prodromal state for many rosacea patients. So that means that maybe down the road, they'll develop rosacea, and you need to tell them that. Does that make sense? And then this was my colleague over here on the right. And you see his face is just red. They look like they're just permanently flushed. He had severe erythrotelangitic rosacea. So when you look at rosacea, it's categorized in different groups, and it needs to be, because the groups of the types of patients will determine how you treat them. So you need to treat what on him? The red. You need to treat what on her? The papules, right. So we're going to talk about his type of rosacea, which is erythrotelangitic rosacea. Many of these people believe it occurs 1, 2, 3, 4 in these phases. In truth, it does not. The other type of rosacea that occurs is ocular rosacea. How many of you have heard of ocular rosacea? More than half the people who have rosacea will have ocular rosacea at some point in their treatment. Okay, that's a given, some point in the disease state. So just be aware, ocular rosacea, always ask about the eyes. How are your eyes doing? So erythrotelangitic rosacea, your problem is dilated blood vessels. And these are usually fixed. They don't come and go. If it came and went, it'd more like the patient was doing what? Blushing or flushing, right? Blushing or flushing. But this is a problem with the blood vessels. How many of you know that the vessel regulator on the face is sitting at the base of the tongue? So that's people, and I have rosacea, by the way, I have a lot of stuff. But I would do public speaking and control that a long time ago. I would put ice chips underneath my tongue because I knew that little spot was there. As long as I had ice in the mouth, I would never flush out, okay? So just be aware of that. That's a good treatment, and also cool soaks. But if they have erythrotelangiectatic rosacea, you want to put the vasoconstrictors, the topical vasoconstrictors on the skin. So before these drugs came out, I used to use Afrin nose spray, right? You got to be careful when you tell people, like if you're going to speak, you're going to do something. I teach my patients, just use some Afrin nose spray and squirt it on there, like an hour before you're going to do it. And you won't be, all red. Well, a patient did it, came back, told me, she said, well, I did it. I said, didn't work? She said, no, I squirted up my nose twice. So be very careful if you decide to use off-label on the cheeks, forehead, etc., that they know that's where they're supposed to put it. It's just once a day, these creams both of them are highly effective. They just both constrict the blood vessels. They do cost a lot. You'll have to work with pharmaceutical, specialty groups. But some of the insurance really will cover these if they have good insurance. The game changer for rosacea, that is erythrotelangiectatic, which was the bulk of mine, I had some papulopustular, is intense pulsed light. How many of you have heard of IPL or intense pulsed light? Does anybody have it in their office? Do you have a derm practice near you that has it? Yeah, you'll find, and even aesthetic places will have it. But intense pulsed light on the skin is a game changer. It gets rid of all the vessels. I mean, literally, when you get it done, the little red vessels turn blackish gray and they slough off. And they've also found, you'll love this one, ladies. You guys probably won't care at all. We women work much harder on what we look like, don't we? We spend a lot more money on it. Guys, they just get up, they wash their face, go out. How long does it take you to get ready, right? But women are interested in this because with IPL, if you do it once a year, it halts aging of the skin, photoaging. Is that shocking? So I've learned that some time ago. I'm not going to tell you my age, but I'm a little older than what I look. And I would credit most of that to IPL, okay? Also great for rosacea, erythrotelangiectatic phase. If they've got pimples and pustules, not. Papulopustular rosacea, I told you don't use antibiotics. I will tell you, though, that if you get them from a papulopustular stage with oral antibiotics, and they have extended release, 40 milligram doxycycline, it's got 30 milligrams of extended release in truth with 10 milligrams of immediate release. Take it once a day, and that is classed and approved for chronic treatment of rosacea. What I do with these people is I get rid of the pimples and pustules with the rosacea, and I usually combine it with topical ivermectin, that's called Soolantra, or sulfa topical. And what will happen is you can get rid of the papules and pustules, and I try to talk them into the IPL because that's more of a game changer for them. Does that make sense? And then what happens to people if we just don't? By the way, you all do know this is all driven by a bacteria that loves to live in symbiosis with a Demodex mite, right? And things that live symbiotically, if you kill one, you kill the other, right? So the focus of the antibiotic, oral, or the topical antibiotics is to kill the what? The bacteria. Ivermectin kills the Demodex mite. It has been shown that symbiotic treatment to go along with the symbiotic state of the disease, right? So you use ivermectin with an oral or topical antibiotic. Got that? And see why you're doing it. You'll clear almost everybody that way. How many of you have seen the W.C. Fields nose? Yeah. It's a form of granulomatous rosacea. How many of you have seen an entire face that's thickened and all granulomatous from rosacea? is one of the most difficult things to treat. I will tell you, if you don't treat papulopustular rosacea, it will become granulomatous. So that's the point of treating it in the early stages. That is the one progression that's clear. And when you have that, you can try oral antibiotic. Doxycycline will reduce the inflammatory cascade, and it also targets the bacteria specifically associated with it. But I will tell you, the majority of the people have to be treated with isotretinoin, Accutane, right? They have to go on the iPledge program. And then ocular rosacea, you knew, could have occurred at any point in time. And that's where you ask them, are your eyes itchy, dry, or do they burn? And everybody has a different favorite. There's no standardized therapy for this. But I will tell you that sulfa eye drops are a game changer for those people. And you can order those. So triggers. How many of you in the room know you have rosacea? Okay. Anybody know why it became the W.C. Fields nose and why it was named that? Because he was a drinker. Alcohol is a trigger. It's not a trigger for everybody, you know. I don't drink at all anymore, but I could have a glass of wine, it never triggered me, right? I could have 2 glasses of wine or even 3, it would never trigger me. But if I get out in the elements, sun, wind, cold, hot, that's what triggers me. Spicy foods for other people, there's like 100 or 200 triggers for rosacea. Isn't that crazy? People need to learn their own, and there are some people that once they know their triggers, never, ever, ever have another problem because they control it that way. This is an inflammatory disease. So how do you treat your skin? Gently. Nothing rough ever on a rosacea skin. Don't put new elements or new creams or new lotions. They've got something they're comfortable with, keep using it. It's the right thing for them. They've got something they keep breaking out with, stop using it, find something else. So we talked a lot about cyclins today, so some tips on cyclins. The first thing I've written, take a full glass of water and don't lay down. Do you ever notice that when your patients are your best friends, do you ever notice they don't listen to you very well? And I figured out why, because they're wanting to talk to you about other things. And so I had a very dear friend. He was a gentleman that had open heart surgery, and I had to put him on a cyclin for a different reason than what we're talking about right now. But I told him, no matter what, don't take your doxycycline or any cyclin and lay down right away. Because what happens? They develop severe esophagitis. Severe. And so he'd had open heart surgery. So what do you think he went home and did? Laid down after he took his doxycycline, so he developed what? Esophagitis. Then he developed what symptom? Chest pain. Then he had to call and then he had to be worked up in the 4. You got it. All right. So I don't think you'll forget that, but it's a common teaching point. I'm going to tell you what a crazy person I am. A couple of weeks ago, I saw a young girl out on the highway next to our business that we own. And she was in distress, and this older guy had pulled over, and I sort of slowed down just a little bit and saw she was crying. And very young girl, sort of reminded me of Gabby Petito. And so I went on to our business and came back, and this older man that was trying to help her, I realized I needed to stop and help her. And so anyway, we stopped, and she's crying. She's got one of those little shocker things, trying to protect herself. And I just stuck my head out the window, and I said, my name's Kathy, and I'm a nurse. I didn't even get to nurse practitioner. Do you know all the people that had tried to calm her? No one can calm anybody like a nurse. Y'all own that? We own that, don't we? Anyway, the police came because she was being physically assaulted by a 40-year-old guy. She was like 23, and she'd been living with him off the grid, crazy, covered in ticks and a million other things. So I told them, the police, don't put her in a shelter if they won't take her. So an hour later, knocking on the door, she's living with me now. And the thing I bring it up for is she had ticks all over. She had strep throat. She had folliculitis. And they put her on. What would you put her on? Yeah, the protocols and many ambulatories put them on doxy for strep throat. It's not my preferred, but they did. But it also covered the ticks, right? So she laid down downstairs in my bedroom, and I don't know how long she'll live with us. She's got Asperger's, very bright, but she was going to be a Gabby Petito. That initial impression was not wrong. But anyway, it's like she had chest pain. She came up, I'm having chest pain. So when they ordered it, they didn't tell her, and again, it runs around again. I have to say that's from your doxycycline. Sit up for a while, you give her an antacid, and she's fine. It will negate the effect of the doxycycline. But just be aware, it's just an undertaught thing. Many people seek urgent care because you forget to tell them that they need to not lay down. Full glass of water when you take it. Not a half a glass, got to drink the whole thing. Should you drink milk instead? No, it'll bind with the cyclin, so it won't work. And then don't co-administer aluminum, magnesium, zinc, calcium, bismuth, things that we see in antacids, right? So I had to take one, so the doxy wasn't going to work for that. And then the photosensitivity problem is big with which two cyclins? Doxy and tetra. It's virtually non-existent with minocycline. But what does minocycline have that the other cyclins do not have? Vertigo and neurologic and pseudotumor cerebri, okay? So be aware, every cyclin has its own unique thing, but these drugs do have some side effects and can cost the health system a lot of money if you don't share it. By the way, people ask me, the last conference, she was the topic of discussion because I made the mistake of telling that story, so they wanted to know how she was doing because she texts me all the time. I don't know when she'll leave my home. Everybody asks that, and my only answer is when she's better. She's got Asperger's with a high Q of about 140, and yet she was a Gabby Petito wannabe. And I look here in Denver, do the number of homeless people in these tents sort of bug you? Just heartbreaking, isn't it? I suspect if we stopped and helped them one at a time, the world would change. That's my preaching. Comorbids of rosacea. When you look at your rosacea patient, do you think you got rosacea with that pretty little thing in your hair? Should I worry about telling her there's a risk of aneurysms? How do you approach these comorbids? And again, are they causative or correlational? You guys will remember that. They're correlational. Take a family history. This is a strong enough correlation to take a family history. And I certainly wouldn't tell anybody, I think you're going to have an aneurysm, and I wouldn't send them to their medical physician or their medical NP or internist NP or PA or whomever and say, she's got rosacea. Let's look for an aneurysm. You'll look like a fool. But take a family history. I have rosacea. I have an aunt and a mother who had aneurysms. Okay? Now, ask me if I've had an MRA in my head. I have not. But be aware the correlation does exist. Strong family history warrants an analysis. Parkinson's. I have an essential tremor at times, but I don't have Parkinson's. But, take that family history. You can certainly ask. And sometimes if you've got a person who doesn't get all weirded out, just tell them there's increased risk. Malignancies including liver malignancies, skin cancer, and breast cancer. And there are specific cytokines. And again, what are cytokines? They're chemicals that are cell messengers, right? That's all that word means. They're called leukotrienes when the cells are white blood cells. Leukotrienes are a type of cytokine. All this stuff's really easy. It's not hard. But the cytokines released include tumor necrosis factor like TNF. Have you heard of diseases that are related to TNF? You heard of medicines that are called TNF blockers? What are those medicines? Yeah, Remicade. They're drugs for psoriasis. So all of these inflammatory markers are showing up over and over again in different inflammatory disease states. We find this increasingly interesting. Interleukin-37 and the toll-like receptor 2. Also, the antimicrobial peptide and cathelicidin are very important in rosacea. So that's where the research is sitting on it now. What's your favorite lesion of the day with all your patients if you look at their skin? Seborrheic keratosis, right? Why does seborrheic keratosis occur? You think it's from the sun? Raise your hand if you think it's sun. Sun? Anybody? You're afraid to answer any of my questions now because you know I'm going to trick you. It's senescence age. And I really hate saying that because I don't want to tell somebody, you can get it when you're 30, you know. I just started to get 2. My poor husband's had them for a while. But, and I know how to scrape mine off. But seborrheic keratosis, there are 2 genes. The good news is I'm not going to tell you the gene numbers are pretty long. But there are 2 genes that are suppressor genes that live inside the keratinocyte. And they tell the keratinocyte the perfect amount of keratin put out every day. I mean, it's a miracle. We could have another science fiction movie. It'd be called the seborrheic keratosis people, covered with them, right? To go along with the wart people. But so these genes control this. I think the body's really amazing. Are you all ever amazed by it? The deeper we dive, the more you realize this probably isn't circumstance, but you know, I don't know. But it's amazing that these 2 genes work all the time. And then all of a sudden, one will fail or both will fail, and that's why you get seborrheic keratosis. So I never tell people they're old age spots. I don't know who in the world ever named them liver spots. Where in the world, right? They get nicknamed a lot of things. Just call them seborrheic keratosis. And there are 2 genes that control the perfect amount of keratin. One or both quit working. Easy? What's the treatment? My favorite one's first answer there. Ignore. And always remember, with any cosmetic lesion, you have to assess, is it going to look better like it was untreated, or look better after I treat it? And then the second question is, how am I going to feel if it looks worse, right? And I have to deal with that. So, you know, you can offer them treatments. I will tell you, treating seborrheic keratosis, the studies show, and how many are familiar with actinic keratosis? You know how long you have to freeze to do it right, according to the research? 8 seconds. I don't know a Texas cattle rancher that would let me freeze their skin for 8 seconds. They're pretty tough, right? So nobody can tolerate that. And so what you do is like little burst. And if you gently freeze it with little bursts, I mean, I literally go, do you all freeze that way? It works better specifically and more importantly for cosmetic. You know, if I left someone hypopigmented from overfreezing actinic keratosis, I could defend myself. If I left them hypo or hyperpigmented from an SK, I could not, right? So do short little bursts. But you know, the best thing to teach them is moisturize the skin with a really thick cream. And I love any of the thick creams, CeraVe, Cetaphil, Aveeno, doesn't matter what kind. Let it sit for 15 minutes or 30 minutes. Don't try to do your whole body if you've got a whole lot of them. But then take a little scrubber like lava soap or a pumice stone, and you can scrub them right off with water. Don't do them all, you know, pick an area, a little area, and teach them to do that. I shared that with one patient. She's just one of those really cute women that got them way too young and got way too many, and she didn't like them. So I told her, well, the vets and the older guys, I always have them use lava soap. Well, she thought it'd be a good idea. So she went on Amazon and bought a gallon of liquid lava soap. So she tells me this, I'm thinking, oh my gosh, she's going to be broke out all over with contact and irritant dermatitis. Nope, slick as a whistle. I don't know if I'd recommend it, but it's just sort of a good story. They came out with hydrogen peroxide gel, but in truth, 40% hydrogen peroxide by itself without the gel. You can use it on those areas, but you have to watch it, treat it a short period of time, like 15 seconds, see if it, you know, falls off. If it doesn't, wait a day or two and retreat. They came out with the gel on the sticks. Anybody ever try them? It's like $200 a stick, and they only did like 2 or 3 seborrheic keratosis. So I don't think they're even out there anymore. If they rapidly grow, they change color, they bleed, biopsy them. Do you all know how to do a shave biopsy? How many of you do it with just a plain razor and regular everyday gloves? That's the way you do it. You don't need to do sterile technique. You can take a razor blade, cut it in half, and shave it right off flat. And that's how a shave biopsy is done. It's a very easy thing to do. Comorbidity of seborrheic keratosis, people who have metabolic syndrome, PCOS, things like that, have a much higher number. Angioma, you guys are familiar with those. What do you tell your people? What do they do to you? That's all people really want to know most of the time. They're worried it's something bad. So what does this do to? So far from me, you've learned genetics or inflammation. What are you going to run with? Genetics. So in this case, the skin, these are in thin-skinned people. And I'm not talking about like if I made him mad and he was thin-skinned. I'm talking about they really have thin skin. And over time, with sun and other things, it will thin the skin out further, and the vessel, the capillary bed, doesn't have enough counter pressure, and it pushes out. It's basic physics, mechanics, whatever. They run in families. So what's my favorite thing to do if they want to? Ignore, but if it bothers them, you can shave them off. You have to cautery them frequently because they do bleed, but do a gentle cautery on a very low level. But if they have a really rapid growth, or if they bleed spontaneously, you always worry about, there are red melanomas. Have you ever seen something that looked like this that ended up being a melanoma? I've had 2. So be careful. Hidradenitis suppurativa or hidradenitis suppurativa, whichever you prefer. We won't do a study to see who says what here. What do you think it's due to? Infection or inflammation? Inflammation, right? There are some genetics with this too, though. But it's an inflammatory cascade, and people are predisposed to it. And you can see just looking at this poor patient of mine, you see she has an active, what some people, that pink area there, they think that was an abscess, but you can tell all through here, what's that? Scar tissue and hyperpigmentation. This is a horrible disease state. And frequently it occurs not just here. Where else is its favorite place to be? In the groin, yeah. And so can you imagine 18 years old and thinking maybe you want to show yourself or something to somebody? You want to engage in intimacy? You're going to want to do that? It really, really impairs quality of life. This is one of the disease states that most impairs quality of life, and it was under-recognized, under-treated for years. One of my favorite things to treat. I will tell you, the majority of people that get a referral for hidradenitis suppurativa have been on doxycycline for years, okay? So problem with that is they're going to develop resistance over time. It does work, but why? Doxycycline is an anti-inflammatory, all right? So it does work, but I don't want antibiotic resistance. Don't want to use it long term. Isotretinoin does work. It's off-label in about 50% of patients. And prior to the FDA-approved adalimumab, which is Humira, TNF blocker, you saw that TNF before just a minute ago, didn't you? You'll see it over and over again. That's sort of an upstream cytokine. But TNF blockers have changed the world for these people. How many of you refer your patients out that have this condition to derm? Good. Or order it yourself? You can order biologics. I know some providers who do. I know most don't because they don't have enough staff to get the drug approved. And then Cosentyx, you're familiar with that drug? That's coming out in the next month or two. Probably is going to be a little more effective. But just to understand the amount of inflammatory cytokines in the tissue, if you just look at TNF alone and no other cytokine, psoriasis, which we think of as the king of inflammatory skin conditions, There's 40 times as much TNF, activated TNF in this tissue. And that's why the dosing is so much higher. Something that does help is to give your patients scripts of either topical metronidazole or topical clindamycin. And when they flare, that will help. Bleach water baths help. In adults, it's a half a cup of bleach in a full tub of water. When do you put your bleach in? At the end. And if you have an isolated lesion that will not, clear up with the drugs, it's not going to clear up. You have to have a surgeon that understands these drugs aren't immune suppressants. They're immune modulators. And they cannot go off their drug for surgery. The only thing you go off biologic drugs, anti-inflammatory drugs for, are orthopedic and gut surgeries. You don't go off of it for anything else. So you have to work with a surgeon who will agree, or if you yourself do excisions. I don't like to remove scarred lesions. I remove a lot of things, but I don't like to cut into scars. They're tough. So I tend to send them to a surgeon I work with frequently that I know will do what I want them to do. All right, comorbids. I told you the quality of life sucks. Sexual dysfunction is obvious. Inflammatory bowel disease, strong correlation with IBD. And depression, metabolic syndrome, inflammatory arthritis, and anxiety, follicular occlusion diseases. And this is a Th17-driven disease, so it affects, those bad acnes and also the scalp acne that people get. That's dissecting cellulitis of the scalp and some other disorders. So they tend to occur together, so it's not unusual to have really bad acne, lesions on your scalp. They're called different things, and then this as well. And treatment tends to improve all. Folliculitis, okay? This is a pretty mild folliculitis. In fact, originally I thought it was insect bites, but it wasn't. It's folliculitis. So the first thing you got to ask yourself, what's the cause of this folliculitis? What are your options for the cause? If it's bacterial, how will it feel? It'll hurt, right? But guess what? Viruses do what? Hurt. How different is the hurt between a bacteria and a virus? How do they describe shingles? Burning, tingling, okay? Where bacteria is more of a dull pain, right? Does that make sense? And if it's yeast, what does yeast do? Itch. So a lot of times you never have to culture. And this is a case where I don't culture. And I love culturing, but I don't, unless they don't respond to therapy. I do this more on symptomatology. Again, bleach water baths, sulfa washes are the bomb because they tend to help a lot of things. Culture, if indicated. When would that be indicated? Huh? Yeah, they're not any better. Symptoms change, they get worse. Culture it. Nick the lesion. And then be aware of what happens in hot tubs. What's hot tub folliculitis due to? Pseudomonas. And so most of the drugs you use for folliculitis will not work for Pseudomonas folliculitis or hot tub folliculitis. Always ask about the hot tubs. And then on people who keep getting this, get the laser out or send them to someone who will do it for you and remove their hair in the area if they want that done. And that controls folliculitis if they tend to get recurrent. Cellulitis. Most of the stuff that I see that is sent to me is not cellulitis. This is cellulitis because her cat bit her on the back of her, ankle. And she got cellulitis from that. So a lot of what we think is cellulitis is actually venous stasis dermatitis, and that's why I've clumped the next one in after this. So if you do think it's cellulitis, culture, culture, culture. If you think it's yeast cellulitis, which is Miyake's, and I've got a separate little slide on that, do a KOH if you've got access to it, but again, make sure it's cellulitis. It gets confused with venous stasis. If the patient's low risk and you're waiting for your culture, do first-generation cephalosporins. What's the most common first-generation cephalosporin that you guys use? Keflex. If they're in a high-risk area and you're really concerned or the anatomy's bad, you can do an ultrasound in your office. How many of you have the little pocket ultrasound? It's helpful because sometimes when they don't heal, there's a little abscess, and you can easily drain the abscess. I think those things are $500-600 now. They're pretty cheap. So much technology is cheap, 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 and not used. And then if you're pretty sure it's hot tub, what's going to work on Pseudomonas, even though I hate the category of medicine? Fluoroquinolones. I think Wendy did a wonderful job of explaining. She feels the same way about it that I do, and she's a good friend of mine. But the other thing I'd add to that is the anxiety, insomnia, and neurologic. How many of you have seen it with fluoroquinolones? It's awful when it occurs. I've always questioned that perhaps they're an underlying bipolar too, but I don't really know. But in people that react to a lot of meds, be careful with fluoroquinolones. And then always recognize the risk of a DVT and a PE. This is don't you hate these patients? They're really hard to clear up. How do you clear these people up? This is venous stasis dermatitis. You're not sure? Is that what you're saying? Well, I tell you, we got all the wound clinic failures. Oh, yeah. In fact, I'm on a sabbatical because I'm working for Full Practice Authority for the state of Missouri, and I can't tell you anything more frustrating than I've done in my life. But I had to have a friend that brought her husband over because they'd been to the wound clinic for a year and a half. He was diabetic with what they were describing as venous stasis ulcers, which in this case it wasn't. It was infectious cellulitis. He'd had it off and on for a year and a half, diabetic, and I sent him off, but by the time between when I said he needed to be seen right away was a month. He got septic, had to go to the ER, and had part of his foot taken off. So, yeah, so make sure it is what you think it is. But the thing you need to do is reduce the swelling. Reduce the swelling. You can't clear these things unless you work on that. Don't throw antibiotics at these people. The majority of these cases are not infected. They're just not. And if you do a culture on them, what do you end up getting back on your culture? A mixed, non-specific. So antibiotics almost never work. How many of you do Una boots? Yay, I love you guys. They're easy to do, aren't they? And so on these people, rule out the infection. If that infection's not there, put some steroid cream on there. Just tack, and then put the Una boot on top. And do you change your alls weekly or every other day or? Yeah. In the beginning, if they look real bad and you're worried, you can change it twice a week or every other day. But after the first week, and they're starting to shrink down just once a week, and you can clear them up most of the time with an Una boot with tack. And again, you want to keep the biofilms down. You do that with bleach water baths. Talk about low sodium diets. A lot of these people, consider themselves as low sodium. But where do you get most of your sodium at? Salt shaker? Salt shaker, right? And they say, I don't salt my food. Sodium in food is a leftover when we didn't know how to preserve food properly, and they need to get rid of it. They put so many preservatives. 85% of sodium intake is from things in a can, a box, or a bag. Is that easy enough to remember? You start working on that, then people really realize. And look at low sodium green beans. You ever look at it? It's too much sodium. So even the low sodium stuff's too much. You got to start teaching them to cook things fresh. How many of you are into that? Yeah, makes a big difference. I use a lot of umbilical cord tissue and placental tissue. Have you all heard of the umbilical cord tissue? And Number one, it's not from aborted fetus. You have to say that right away. Don't put that on my leg if you killed a baby. No, I didn't kill a baby. These are from healthy mothers who choose to donate. And these things really, really, once you put them in the wound, they really, really change. If you're not doing it yourself, send them to somebody who does. Wound clinics tend not to do a lot of it because it's expensive and you don't make as much money as you do by packing it with a cheaper substance. I'm a big believer, and I didn't put that on there, of silver containing impregnated products like Silver Cell and Prisma. Anybody use that? It's a game changer, isn't it? Yeah, so it just naturally sort of works to heal that up. And then even if their cholesterol levels are not high, if you put them on low-dose statins, just a low-dose statin daily until the ulcer heals, along with Plavix, and the generic name is there for you, I hate to say it, that will work. Elevate the legs, do compression treatment, and above all, send them for venous evaluation and also arterial evaluation. Do you all do that? A lot of times once you fix these incompetent veins, they never have a problem again. It seems to me like the older you get, unless you keep yourself up, patients don't get as much care as they would get if they were 30 years younger, right? And I'm a person who believes that just because someone's 70, they shouldn't have to run, or 80, shouldn't have to run around with that on their legs for the rest of their life, even if it's a year. Comorbidities, diabetes, neuropathy, PAD, and PVED, and COPD. Atopic dermatitis, again, old word we use, eczema. Do you remember why we use the word atopic derm? Oh gosh, I love you, coverage. Have all those notes say atopic derm. It makes it much easier. What do you see on this individual? He came to me wanting to file a lawsuit against the owner of the home that he lived in because it didn't have a basement and it got wet under there, and he was convinced he had black mold. So what I did was do everything I could to reduce that fear, but then we began to talk about other things in his life. He had, other issues, chronic allergies. He had esophagus. He had the typical stuff that all these people have. But looking at him, what do you see? I didn't show you a rash. Do you see the allergy pleats, what we also call Denny-Morgan lines? And some people say Morgan-Denny. In fact, I think Wendy says Morgan-Denny, but it's the same. You see the pleats under his eyelids, and you see the shiners. They occur in adults too. That he was itchy all over. So, number one, with all atopic derm, it's the itch that rashes. So what do I have to control? And how am I going to control it? Antihistamines. And in this age group, am I going to use a first-generation antihistamine? Why? Because I'm afraid there might be something significant in the correlational, not causative data that exists between dementia, first-generation antihistamines, and bladder control drugs, okay? So that's why we do that. And so I'll dose a Claritin, Zysol, Zyrtec, your choice, morning, and I'll dose another one in the afternoon and another one at night. I don't give them to them at the same time, because if you look at the curves on the blood levels, you'll see why you overlap in that way. You can really go up to 4 to 8 times the dose. 2 things you need to remember about prescribing antihistamines. What are they? And particularly if you're going to dose them up. Can they see and pee okay? So I had an attorney patient, and I have to be careful to keep my word talk down where it needs to be. So he and I are always talking about all kinds of fun stuff, and I said, well, do you see and pee okay? What does that stand for? CMP, right? CMP. So I had to say, well, Mark, I'm telling you, it just means, can you see okay and you pee okay? I've learned if you sort of do this along with it, they get the point. Because in certain types of glaucoma, antihistamines are not recommended, and certainly high-dose antihistamines can put them into an acute glaucoma episode. So you need to run that by the ophthalmologist. Certainly if they have a history of it, there's certain types of glaucoma you can, as you well know, and certain types you can't. And then frequently people can't urinate well. And in fact, I have learned you don't need a bladder control med. You can take even a second generation antihistamine. Oh, you're shaking your head up and down. Everybody knows. You want to sleep all night? Take a second generation antihistamine. Probably not going to hurt you. And you won't be up urinating at night. I try to get my husband to do that. He hasn't gone along with it. Low to high potency steroids depends upon location. Frequently, again, they leave with 2 types based on where they're going to be putting it. And I love topical calcineurin inhibitors. Do you remember that these are topical medicines that came from a family of drugs that do what? Suppress organ transplant rejection. So if you want to keep that implanted liver and kidney and whatever, you need to take this type of drug orally, IV, but they formulated it for it to go on the skin. And the only way you're going to get skin cancer that it says on the label is if you eat your tube. Good. So Opzelura is a game changer. This is a JAK-STAT pathway inhibitor. And it would take me an hour to explain all these pathways to you, and you'd also fall asleep. So just be aware, the JAK pathway treatment drugs are going to change the face of many medications, but particularly dermatology. Very expensive. I told you before, it's about $800 up to $1,000. And then we do have the Eucrisa. Do you remember what I told you about that one? It burns, so what do you have to do? Steroid first, wait 30 minutes. You guys remember a lot. If they don't get better, think of allergy testing and patch testing. So allergy testing is, what? How do you do it? Do you send them to an allergist? You can. But the type of allergy testing they do, where they inject underneath the skin, is the same thing in terms of results as the blood panels. Okay, they're called immunicaps. And you can order specific things you might be allergic to, or they may be allergic to, or you can send them to an allergist and have their back injected. The allergist would prefer that you keep sending them to them, but it's much cheaper for the patient for you to do an immunicap. And those are done in regions. Another funny story, I wrote on a patient's, wherever I go to work, I always order a lot of stuff and people aren't used to it. So it was at a local hospital, and I sent a patient over for Region 7 and food panel. So the regional means where you live at. So if you get your Quest lab book out or whatever lab book, it'll tell you the stuff that's tested for routinely in the place you live. So the director of the lab called me. They said, what part of the body do we need to draw this blood from? Funny, isn't it? So you guys will remember that. That's the area they live in. And then patch testing, you can actually order patch testing kits off Amazon. And they'll tell you how to do it. And you can put the substance, if you have a specific substance that you want to patch test for, in that. Everything's on Amazon. It's probably on, is it Alibaba, the one from China as well. But the game changers you had earlier today are dupilumab, tralokinumab, and the new oral JAK, Simbinco. Okay, these are game changers. So these people don't run around itchy, not sleeping, and miserable for the rest of their life. So just be aware of those drugs. I don't expect you to prescribe them. I expect you to know that they're there, so you're not injecting them with their monthly triamcinolone and giving them a Medrol dose pack, which will actually exacerbate the disease. We already went over these, and I think you have a good feel for that. So again, this is an inside out, outside in. It's a Th2 T helper cell, right? T lymphocyte helper cell that promotes IL-4 and IL-13 as well as others. And there's also a flagger mutation in the skin, and that's genetic. These are the comorbids. It's getting longer in the day, so I'm going to speed it up. You all look a little tired. This is contact dermatitis. And this young man, he was the son of the president of our local university, and I'd worked with him for a while on this spot. And I finally said, he was into sports. So I said, when you come see me next time, I'd taken a history, thought I'd covered every base. I will tell you, with contact dermatitis, you make the diagnosis with the history, or have them dress like whatever it is you think. And so I had him dress up for his sport, and I found this little thing he was putting right over. He couldn't tell me. I said before, is there anything you put right over that exact spot? Because it's so perfect. And that's sort of how contact dermatitis runs, unless it's due to rue or poison ivy. So it's pretty fun. Same treatment, consider patch testing. But again, the history and the location will help you a lot. All you men are a little nervous. Look at him grimacing. All right, so the first is tinea fungal infections. That's onychomycosis. The second one's a funny story. It was a colleague over across the river that had been treating this poor guy for, I want to say, a year. It's somewhere close to that. And he kept treating him for tinea right here, over and over again. He had that catheter put in. He's diabetic. Had that catheter put in a couple days before because he kept telling him, you must be peeing on yourself, and it's that. And the guy kept saying, I'm not peeing on myself. So the wife and the guy was brought in with this catheter in, and he had erythrasma. So you diagnosed that. Number one, they didn't get better, right? What else behaves? And this burns. If somebody would have asked him, he'd have told them it burned. This other stuff will itch. This burns. He had erythrasma, and by the time he got ready to go to the pharmacy, had fever, because I told him if you get fever with that catheter and with diabetes, go to the ER, and he was septic. So if you've got tinea that doesn't respond, particularly in this area, think erythrasma, which is a bacterial infection that is chronic. You know who that picture is right there? So I'm supposed to know quite a bit about this stuff, but that's me. I've been to Mexico. In fact, that's the dress I had worn in Mexico about a month before that, and I kept itching right here. So I have a lot of patients to see, 40, 50 a day, and I'd say, hey, would you go back, or I'll go back and I'll get that high-potency steroid, and I just kept putting it right there because it was itching. Never looked at the spot. Finally looked at it, and what do I have? Tinea incognito. Okay, so it's tinea made worse by the very stupid application of a dermatology provider who speaks for a living on the topic. Now, I don't speak for a living, but I do get paid for it. And it just goes to show, look at everything. Okay, so you can very clearly, that's tinea incognito. The first thing you need to tell people about any tinea infection is that treating yeast and fungi takes longer until you're better. Set your expectations up for this one. And particularly now that the antifungal agents we've been using topically for a long time, how many of you notice ketoconazole doesn't do as much as it used to do, right? It's increasingly not working on these infections. How many of you have seen, too, there's a candida species that's killing people? Did you see that in the news? It was 3 or 4 weeks ago. So I think it will go the path of bacteria over time with all this. But just tell them it's going to take longer to clear it up. You're talking 2 weeks, 3 weeks, 4 weeks frequently. Don't make them think they're going to be better like when they got their strep throat and they were better in 2 days. I use vinegar 1-to-1 or 1-to-2 ratios at time. So I use white vinegar mixed with water, and however you mix it, and you can soak it or put a rag on top, but it works great on fungus at reducing the itch. But I also use my lovely bleach water baths. Any of the azole antifungal creams, again, resistance is a problem, and you got to treat till clear, and I treat till about 3 days after clear, but there's no data on that. And again, tinea crus, what do you remember after that picture? You've been treating them for that long. This was a dermatology provider. It was really a sad situation that was doing it. Think erythrasma. How many of you have a blue light? Yeah, you can shine that there and it'll fluoresce coral red. Okay? So if you have one of those, We used to have them in my day. That tells you how old I was. Those lights. Usually Augmentin works well. Augmentin 875 twice a day. And this is what happens if you leave tinea too long. It runs down the hair follicle. It runs down the hair follicle. Is it on the surface of the skin now? No, it's deep, and it's called Miyakis. And the reason I bring it up is if tinea is not treated soon enough, you'll be treating Miyakis, and that requires not topical treatment. It now requires oral treatment. And when you treat orally, the drugs are there and the duration. It's your call on CBC and LFT. I'm an over lab doer, particularly because I think as NPs, PAs, we have to prove ourselves a little more, don't we? Be more careful. Onychomycosis. And this is actually my mother's toenail. She was 96 when she died. She was actually one of those people that she was given the J&J vaccine when she was 95, and she had a sudden decline. You know, that was no go for COVID on women over 55 because of she had one of the events from that. So she had severe decline. So we took care of her at home, and she had horrible toenails, and she always wanted to go again and get them fixed. But I know what the podiatrists use. Do you know what they use? A Dremel. Do you know they use a Dremel? So I Dremeled it down, and she'd had that toe forever, and actually we got that completely cleared up. You do not have to take oral antifungals. And I have a hard time, even though it's listed there because it's FDA approved, both of them are. The topicals that were highly touted and cost a fortune just don't work very well. Penlac, how many of you use Penlac, Cycloprox? You ever see anybody clear from it? Never, right? And that's true for the others that, you know, I used to tell people, like, don't get a manicure or pedicure because there's two people that go in there, people that have nail infection and people that want to look better, and pretty soon they all have a nail infection, right? So I went in and got a pedicure done for our wedding, and I had a early case of onychomycosis, and that stuff costs $750 a month. Can you imagine paying it? And because mine was early, it did work. In my mother's case, so I read this stuff on the bleach pens. How many of you know that bleach pens have really dilute bleach in them? They do. So if you put Vaseline around the rim and use a bleach pen on nails that are prone to fungus or already have fungus, you can take care of them. That's my little tip that's off-label, and it works. You know why it'll never be on-label? There's no money for pharmaceuticals to... Huh? Vicks helps, yeah, and I do recommend it. I do recommend Vicks nightly. It does help. It's also one thing that is never going to be funded, but the bleach pen works a little better, believe it or not. And I had used the Vicks Vapor Rub around. Was that you that asked that about Vicks? Whoever said it? Yeah. Do it around the edge instead of Vaseline, and then put the bleach pen over it. This is shingles. What happens here? Oh, I wanted to tell you something on this one. So that shingles on the right, you can tell that was with an older camera. But it's always on a dermatome, right? And this one on the left was with my newer camera. It happened to occur in 2021. What did they have? COVID or the vaccine. Both COVID and the vaccine causes shingles. And I wouldn't say cause it, it causes it to flare because shingles is always there, right? It's just whether or not it's coming out to the skin. So that gentleman was a vaccine. So it reactivates the varicella zoster. These are the drugs that you can use. What's the big thing you need to remember about antivirals? Yes? I don't know enough data on that. Yeah, I wish I did. That's a good question. You're going to make me go home and read. Good question. Does it help to have had the vaccine, the shingles vaccine? I would say probably, but I don't know for sure. But the thing you need to remember with the antivirals is, you know, kidneys fail from antivirals if they're not adequately hydrated. One of the worst lawsuits I ever read was for herpes labialis. They were given Valtrex, golfer, went out on the golf course, got dehydrated, didn't drink enough fluids, drinking beer all day long, not enough otherwise fluids, and went into renal failure, died. That lawsuit was massive. Also be aware of post-herpetic pain. What do you guys use? Gabapentin, but always remember, what does gabapentin do to a soul? Makes them dumb and fat. Never forget that with gabapentin. If people are on gabapentin for a long time, they universally gain weight and they're not as quick. It's just the way it is. So if you can use a lidocaine patch, use the patch. You can also use capsaicin patches or capsaicin gel. It works very well. It blocks the signaling. And that's for post-herpetic pain. After the shingles is gone, what's there? This is herpes labialis. It's just herpes on the lip. One thing to know about this, I think it's important to know, is know that treating it topically initially is better than treating it with oral. But long-term suppression, it's better to use orals. Topicals are less effective. So over time, topicals are less effective, but initially they're better than orals. And a new topical way, how many of you have heard of the Stavig patch that sits right in here? So it's acyclovir on a patch, and you just stick this on your gum on the side when you first start the symptoms, stick it up there, and they won't progress. So it's great. And then topical acyclovir has to be applied frequently, but the big thing to remember is sun is a trigger, it's a trigger, it's a trigger. And everybody has this and that and the other they swear by, and if they swear by and it works, I'm for it. But I will tell you there's no good documented evidence, but we all know sun's a trigger. Use sunblock all the time. If you get on the lip, you got sunblock on that lip all year long. And this is just itching. And most of this you know already, but just be aware, people who are consistently itching, there is something wrong with them. You just don't know what it is yet, okay? So if they have chronic itching and you treat them for atopic derm, and a lot of people in derm, we just put them on dupilumab because we know right away, you know, if it's something we're going to have to work up and it's so safe, or Dupixent. But also if they're like itching right here, what would you think? It's only there. They've been itching for a year, only there. What would that area be? Or maybe it'd be right here, from here down to here. Think disc disease. Disc disease not only causes numbness and pain, it also causes itching. So if it's on a dermatome, work up the dermatome. So I'm working it up. If it's on here, I'd ask, do you have a lot of neck pain? Oh, yeah, I had surgery. You know what I mean? You'll find out. Here, do you have a lot of back pain? Whatever. So, and that's my initial workup. If I have to do more than that, I'm sending them. But also know kidney disease, liver disease, lymphomas. Everybody I've worked up for chronic itch, I found a problem. Unfortunately, many of those led to their ultimate demise. So never stop on itch. Don't say it's in their head. Their skin's telling you something. You just don't know what it is yet. Cold is the bomb for controlling itch. I like to do frozen corn or frozen peas. You have to put an X on it so you don't forget and cook it if it's been used a lot, but recurrently freeze that and just slap it on the areas that itch. And the reason I like that over the packs is it molds to the skin better than the packs. You ever tried those packs? They just don't mold very well. But the peas and corns do great. And these are the comorbids. The important one to remember is mycosis fungoides. This is missed all the time. People die. I had an intensive care director that died of mycosis fungoides despite being worked up for atopic dermatitis and treated for 6 years. Finally diagnosed at the end right before her demise. Do not forget that. and look at my psychiatric overdiagnosed, see that 10 to 50% at least have chronic disease. Epidermoid cyst, the only thing I'm going to say on that, it needs to be called an epidermoid cyst. It's not a sebaceous cyst. It sits in the epidermis. If you're going, how many of you will remove epidermoid cyst in the room? Put your hand up. Okay, good. Know your anatomy, and be careful in areas that have a lot of sun damage. A lot of people with bad sun damage of their face have something called fovea rachosat, and they will have cysts all over their face and scars. If you go in and try to remove that there, you're just going to scar them even more. It's impossible to close. So sometimes with, these aren't infected. You know that, right? All right, they're not infected. It's just a plugged up, epidermoid structure, and the cystic material builds up in there. It's very easy. Anybody do a punch biopsy? It's the first thing I ever published. It's either clinical advisor or consultant. I'm not going to tell you what year it is. I'll tell you how old I was. But you can take these out so easily with just a punch technique. It's a lot easier for the patient and for you to do that, because otherwise you're in there for quite a while and the patient is too excising it. Keloids, hypertrophic scars. This poor guy, he was a banker, nicest guy on the planet. He had these his whole life. It always bothered him. He would never go out swimming without a shirt. And what do you think he got them from? Look at those. Make a guess. Spot on, acne. Okay, this is why you treat acne, is to prevent scarring. And it's a much bigger problem with a higher number of Fitz level skin. So he was so happy, because what did I do? Do y'all remember? Inject with triamcinolone and freeze, cryo, right. So also know that in adjunct therapy can be the silicone gel or patches. Do you know where you can get that? Amazon. It does help. Injectable cryo I already talked to you about, and I think you know the rest. How many of you see a lot of this? Vitiligo. Okay. How do I know that's vitiligo and not like, tinea versicolor or something like that, or pityriasis alba? Why do I know? When you look at the edge, what does the edge look like? Sharp, clear demarcation, that's vitiligo. Vitiligo has a sharp, clear line between the pale skin and the dark skin, your normal skin. So I used to inject a lot of these with triamcinolone. It does help. Also super potent, the highest potency steroids you can put on them, giving them a break every other 10 days or so for a week. I used to put them in the UVB light, which is a light box. You can get those for patients. It helps a lot, but never use UVA. It's similar tanning, but it's more focused. You can also use the protopic, and the other drug that are used for what? Organ transplant rejection, but not going to cause cancer unless you eat the tube. The real game changers are the JAKs. You can take a person, how many of you have seen the commercials? Are all over TV on this. You can take people who've had vitiligo for a long time, and it actually works better on the face than on the extremities. You can clear them up. They actually clear up now. So it's something that you really need to refer patients out for. Don't let people stay with vitiligo unless they want to stay with it. These are comorbids. This is erythema ab egnei. So this is a patient of mine who came in, and she's so very poor. And one of the deals I always make with everybody I work with is you have to let me agree to see like 10% of my patients free or do X number of patients free. And they always agree to do that. So she was one of those people who came in. She was in a relationship with a guy who was very worried that his pretty partner, who suddenly wasn't so pretty anymore and particularly just had a baby, and they were very poor. And I kept asking, because this is erythema ab egnei, right? What you might call it livedo reticularis. The difference is livedo reticularis is that lacy. Do you ever notice people on their legs who have a lacy pattern? But it's not this dramatic. You can barely see it, and there's a mild associated with connective tissue disease. This is definitely a pattern that's unique. The only pattern you're going to see like this is erythema ab egnei, okay? And it's a heat source. So in my discussion, I kept saying, man, you just only see this with heat. And are you sure you're not using, because you're told not to use what? Local little plug-in electric heaters and stuff like that, and people know they'll get a lecture. And she finally admitted she was using it. So she was using it because they had no heat in their home. Isn't that awful? No heat, and that's the only thing she could keep her legs warm with. And so here you are. You got to stop at this point and call social services to get in there to make sure their heat gets turned on and paid for. So that's what we did for her. And we also used a retinoid cream. I did not have to use 5-FU. If you do not treat this, it can become permanent. Most of the time, when it's that dramatic, it will be permanent. If you catch it early and it's mild, just stopping the heat source is usually enough. Capillaritis versus vasculitis. Now we're talking about autoimmune, immune responses in the vessels, right? And capillaritis can be much more benign. In this particular, what I'm showing you here is capillaritis. Von Schomburg's disease is the fancy name for it. But capillaritis will have petechiae or purpura, okay? Petechiae or purpura. What do you usually get if you see petechiae? What's your first go-to thing you're going to do for the patient? And I would do it too in this setting. I did. What would you order on the patient? Platelet count. It was normal. So these people usually have been standing for long periods of time, and they simply need to learn to sit and put their legs up and use compression stockings. If you have palpable purpura, there are some small vessel vasculitis that can be a little more serious. Medium vessel vasculitis are the big bad vasculitises, and they will have some petechiae, some purpura, but if you feel, you're going to feel nodules, okay? Versus large vessel vasculitis is things like temporal arteritis. Remember that? You don't see anything on the skin too deep. This is photosensitivity, and you can tell that because it's in a classic pattern. This is my daughter-in-law. She has Crohn's disease, and I talked her into going on a TNF-alpha blocker for her Crohn's disease. And she either had a reaction to the TNF blocker or just plain photosensitivity. Biopsy favored photosensitivity, but she was switched. So when you see that, that's just a sensitivity to UV light. Look for the medicines they're on, because drugs like cyclins, you already know TNF-alphas, we could go on the number of drugs that cause photosensitivity. But it'll be in a pattern, and you can tell. You always get an ANA on these people, and these are people that I repeat the ANA every 2 years, even if it's normal the first go-round. Because this is a spectral disease. They can start off with photosensitivity and land over in lupus land. So the first time I saw this patient, skin was totally clear. She'd been going to the walk-in clinic. Aren't you guys happy that work in ambulatory care? She's been coming in every few weeks saying, my skin's broken out. They've faithfully given her a steroid shot and put her on a Medrol dose pack and gave her topical steroids. This is a funny story, actually. But anyway, so I told her she had to stop. And usually I make them stop. You know, they can have no topical steroids if you're referring them. You don't want any topical steroids on that skin. You don't be giving them oral steroids, and you don't want to give them shots of steroids, because guess what they can't do? They can't biopsy. So just like steroids altered the skin, they altered the biopsy result, so they can't read it correctly. So this gal I had do 3 weeks off. She comes in to see me. Is she liking me in this photo? Look at her face. She's thinking, that walk-in clinic, and she said it too, she knew a whole lot more about this than you do. Look at me. But how do you know this is lupus? Tell me. See the photo distribution pattern? A photo distributed rash like that is lupus, okay? But you need to confirm it. And so it's a chronic autoimmune disease, obviously. It can be limited to the skin only, but often has multi-organ disease, and people can die from lupus. You do a punch biopsy in our setting. If you guys don't do them, that's fine. I will tell you, if you just do a punch biopsy without doing what we call Michelle's or direct immune fluorescence, you'll never diagnose it. So if you don't have Michelle's, refer. And then we've got some treatments and therapies. Always get an ANA on that person, always get a urine. The ANA, just like at the photosensitivity, but the urine, because that's my marker that I use for, is it someone that I need to refer to rheumatology? If there's any protein or blood in the urine, they get referred. Alopecia, all different types, right? So you can see that is dissecting cellulitis of the scalp. You can see that is, alopecia that we talked about, where the immune system attacks the hair follicle, alopecia areata. This is such a hoot when they come in with a bag of hair. And then this is androgenic alopecia, right? We no longer use the words female and male. It's just androgenic alopecia. So telogen is in the resting phase, and the maximum amount of hair in the resting phase is usually about 15% of the hair. The reason you want to know that is that you can tell the person the most you're going to lose is 15% of the hair. And I know in 3 to 6 months you're going to be normal, okay? Because this comes back, telogen effluvium. And this is where the people say their hair, and they're the ones who bring in the bags. Now, in the anagen effluvium, the hair cycle is in the growth phase, and this affects 85% of the hair, roughly. And what are you going to tell these people? Most of your hair is going to be gone, right? Because you only got 15% left. So these are your chemotherapy patients. They have anagen effluvium. Alopecia areata, we discussed earlier, and I'm not going to repeat it due to time. Male pattern alopecia, Propecia is a good drug to use. And female pattern, spironolactone is a good drug to use. And in all hair loss, topical and oral minoxidil you want to have in your pocket. And also for people that lose their hair all over, universalis alopecia, like alopecia areata all over, JAK inhibitors are absolute game changers. Absolute game changers. They get their hair back. Psoriasis. This patient on the left sat behind me in church all the time, and she whispered at me, "Would you see me? Because I've had yeast infection for 3 years now, and I keep going to my OBGYN, and it never gets better." So I said, "Sure, come and see me." And I looked down there, and then I did a full skin exam and see what I found on her. What's that? Little area of psoriasis. So what was this? Inverse psoriasis. This patient, oh, darn it, back it up. So this guy over here, been treated for decubitus for over a year. What was it? Inverse psoriasis. So inverse psoriasis is psoriasis that doesn't look like regular psoriasis, but occurs in places like that girl had it here and on the buttock area. And then this on the foot is plantar psoriasis. I actually published this case study because it was a very recalcitrant that actually responded to a very specific drug, and we cleared her right up. No one should have genital, scalp, or palmar-plantar psoriasis and be in your clinic. They should be referred to be placed on a biologic, okay? So if they have it here, scalp, genital, palms, feet, yeah, they got to be referred. So it's an immune-mediated disease. There are chemicals that calm the skin and chemicals that don't calm it that much, and an imbalance of these causes rapid proliferation of the skin. And that is psoriasis. It is a chronic disease. The comorbids are enough to blow you out of the water. Arthritis is the most common comorbid, but heart disease, liver disease, you name it. You can do an entire day just on the comorbids of psoriasis. How many of you have seen porphyria cutaneous tarda? Anybody? Okay, I may skip this one. That's a disease that occurs with Hep C, so if you got a huge Hep C population, be looking for chronic blistering diseases because they're very common to have that as well. Basal cell cancer, it tends to look like a pearly area or a plaque that comes and goes and doesn't heal, or comes and stays. So the guy on the left, he'd been treated for a fungus for 5 years. It was a basal cell cancer. So don't keep cancers. Biopsy them. You can biopsy them. Always know if the margins come back as clear on your biopsy report, that doesn't mean that it's clear. That means you're done, but you got to refer them for an excision. You got that? So it's never really clear just because the margins are clear on the initial biopsy. This is squamous cell cancer. Same thing. Margins clear, they're not, send them on. They need to be properly treated. And this is, it's really not the mother. Merkel cell cancer is the mother, but for everybody's normal purpose, this is melanoma. And the reason I like this slide is you see it's like a heart. And that got read by a pathologist, actually a derm path, as a mildly dysplastic mole. So if you suspect melanoma and you're doing a biopsy, send a picture if you don't agree with it and call the path reader that you really think this is melanoma. So this got upgraded to superficial spreading melanoma with a Breslow depth of 0.25. So melanoma is serious. I always wonder who threw Jimmy Carter's melanoma away in a trash can, right? Because you know he never had a history of melanoma until it was all over his body. It was never found in any eye or any gut or else other places it can occur. So thank you for your very kind attention, and I will answer questions now.
Okay, so we have about 7.5 minutes. Is red light and blue...
I have 9 minutes and 21 seconds. Am I wrong? Okay, go ahead.
Is red light and blue light therapy effective for anti-aging, acne, etc.?
Red light therapy is the most effective for anti-aging. Blue light therapy is more to reduce itch and things like that.
Okay. Have you heard of Silvadene cream for herpes labialis?
I don't use Silvadene cream for herpes
labialis.
Labialis, no.
Yes.
If it's used, I suspect they're using it to prevent a secondary bacterial infection because that occurs often.
Okay. I think you addressed this last time, but there was a question about sunscreen and cancer, the relationship.
I think we always need to look for things that are any topicals that maybe we are systemically picking up in our bloodstream. Yeah, but they're addressing it. Companies are changing the contents all the time of their sunscreens, et cetera. But that's lotions, that's shampoo,
Right.
that's shaving cream, that's everything.
Everything we put on. Do you ever treat patients with ocular rosacea with IPL or oral medication, or just the sulfa?
IPL, they'd be blind, so no. What was the second one?
It says, do you ever treat patients with ocular rosacea with IPL or oral medication, or just the sulfa eye drops?
Yeah, so I use sulfa eye drops. It works on almost everyone. If it doesn't, Oracea, the extended release doxycycline will. Good question, but not the IPL part.
Okay.
You got to have on goggles to get IPL.
So this is a very long one. I have papulopustular rosacea. I'm considering using a retinol to combat aging and lines and wrinkles. I was treated initially with sulfa face wash and ivermectin cream. Now I'm only using this about once a week. Can you recommend an anti-aging skincare regimen?
Number one, clear your rosacea so that it's just, you got baseline skin that's red. Absolutely clear that. Set yourself up for IPL treatments, and I can't stress that enough. I would use combination therapy of cilantro or topical ivermectin with the extended release doxycycline. And then once it's cleared, then use your retinoid. I guarantee you, if you got rosacea, I could not use my retinoids until I got it cleared. Some of the super weak retinoids, the prescription retinoids will work, but they don't work that good for aging. So,
okay. Are you seeing a rise of pyoderma gangrenosum and hidradenitis post-COVID?
Yes. We're seeing everything post-COVID. And I have a COVID pictures I took of patients' lesions that happened during COVID and what they look like. Telogen effluvium has been renamed almost to COVID effluvium because the effluvium they had lasted way longer than 6 months, way more of their hair. How many of you have seen horrible hair loss with COVID? It's awful, isn't it? It's shocking.
That's one of the questions as well, if you are seeing hair loss post-COVID, and what can we do for that? Minoxidil, not just topical. 0.625 milligrams a day, that's on that slide of oral minoxidil for any hair loss can be used.
But you have to be a little careful because you know that's for blood pressure. So co-manage that with primary care, and you are the primary care, so you can.
Okay. And is there any use for laser therapy in hidradenitis suppurativa?
Yes. Get rid of some of the scars. It's not covered well, so if they have a residual, scar area, I do tend to have them excised.
Okay. If we use spironolactone for women with hair loss, when we stop, does the hair loss resume?
You're going to have the hair loss problem. And I also use minoxidil with spironolactone for female hair pattern loss.
And the same thing occurs with minoxidil once you discontinue use the
Correct.
hair loss. Okay. And what dose should we use spironolactone for women with hair loss?
Yeah, I went through that little drill of 25 milligrams at night, wait a week, then 25 in the morning, 25 at night, wait a week, then 50 at night, 25 in the morning, wait a week, and then 50.
50.
But I used to work with cardiac patients, and I saw bad things when people got high doses too quick.
Right. What's your go-to topical anesthetic?
Well, obviously, lidocaine, really. It is my go-to topical. Unless I'm doing a really long procedure, and then I'll use Marcaine or something different. But
okay. Is there anything that we can do to help patients prevent keloid formation? And when they develop, which is better to refer them to, derm or plastics?
Plastics will be more expensive, but talk to your derm to make sure they treat them. I was the only one in my office that would treat keloids and hypertrophic scars the way that I did, because it took so much time and you didn't get paid much for it.
Okay. Is there any change in skin color with bleach baths?
None, no.
Okay. And how do we get JAK inhibitors covered by insurance?
Time, but also get good at sending pictures. Ask for higher appeal level, complain. Really look at the patient history and see if there's other indications like rheumatoid arthritis or something else you can throw in there. It's a challenge, it is. They don't want to pay for all this stuff. I tell you, when we do derm conferences, we get our conferences funded at $1 million, from different vendors. You know why? The drugs cost a fortune. And I'm not into them costing that much, but I also know how much they spent in research and development. And I know everything we know about derm today and treating psoriasis is due to major pharmaceutical companies, not being done anywhere else.
Okay. And do you have any tip to differentiate tinea capitis and androgenetic alopecia?
Tinea capitis, usually those people are a little OCD, right? They're pulling their hair out all the time. Oh, I'm sorry, you said tinea capitis.
Tinea capitis and
androgenic
alopecia.
You'll see a ring and a scale and a difference in hair, where it's more abrupt with alopecia areata. It's more abrupt. In tinea, it's more of a decrease that you'll see.
Okay.
And the hair follicles.
Anything else? We do have 2.5 minutes. 2 minutes.
Oh my gosh. Yeah, go ahead. Yeah. Mm-hmm. Yeah, they definitely need to be I don't care how long they've had it.
Can I repeat the question for those?
Yes, please do.
She just wants to know how we would treat alopecia totalis.
Totalis universalis, okay, you know the difference. Totalis all over, universalis scalp, all of it. Both those settings are JAK candidates, so Janus kinase pathway inhibitor candidates. You just simply need to know that to refer the patient. I don't think primary care at this point in time should be managing that. Now that may change. They're trying to convince us these JAK inhibitors that just got their warning for the fatal blood clots and stuff are totally safe. So I wouldn't want to be in a setting where someone might question should primary care have done that, but definitely refer them out and call and make sure they will use them. I tried to get many patients with universalis and totalis covered prior to the JAKs being approved for things. Insurance companies wouldn't do it, even though they knew the research was in.
All righty. Thank you so much. Wonderful
Thank
presentation.
you.
Thank you very much. Please remember to do your survey for this session. We're going to take a 15-minute break. We'll be back here at 2:45 p.m.
Is this on?
Yes.
You guys rock. You were attentive, you smiled, and you interacted. Thank you so much. Thank you for having me NPACE. I always love NPACE.